Hello, and thank you for joining me today for this video on chronic kidney disease. I will mostly be giving a high-level overview again, since there are many topics that are covered that rightly deserve their own hours-long conversation. We will delve into the major causes and risk factors for chronic kidney disease and the management of CKD and its complications today. When dealing with chronic kidney disease patients, it's important to think about the stage of chronic kidney disease and the cause, if known. If we need additional information, we have our evaluation process for chronic kidney disease, not unlike what we usually do for acute kidney injury. After we establish the stage and cause, we can then focus on the systemic complications of chronic kidney disease, and finally, how we manage these complications. Staging chronic kidney disease is usually the first step in the evaluation of a patient with chronic kidney disease, since it gives us what a patient's kidney prognosis will be in the future. As you can see here, the stage encompasses two markers of kidney function, the first being the glomerular filtration rate on the left, and the second being the amount of proteinuria on the top. The lower the glomerular filtration rate, the higher risk of progression to end-stage renal disease. Note that this is not a risk for death, but rather the risk of ending up on dialysis or needing a kidney transplant. Given the latest medical technology, we can routinely keep patients alive on dialysis for 30 or more years now. So while being on dialysis does increase your risk of mortality, patients can live a long time with renal replacement therapy. The second marker here to note is the proteinuria. The proteinuria is reflective of underlying damage to either the podocyte or basement membrane, and it is another strong predictor of renal disease progression. Hence, it is included here in this figure. The higher the proteinuria levels, the greater the intrinsic damage to the kidney, and hence the more likely a patient is to require dialysis. While proteinuria and GFR are interlinked, proteinuria has been identified as an independent risk factor for kidney disease progression, which is why it is separated from GFR here on this figure. Overall, there are 5 stages of kidney disease, with stages 1 and 2 being very mild and almost considered normal. Most patients will fall under this category when you see them in clinic, and there's not too much to do for these patients. It is only when patients get to stages 3 and higher should we be closely monitoring them for complications to chronic kidney disease, since there are medications we can use to slow the rate of progression of kidney disease. Once a patient's GFR falls below 15, these patients inevitably will need some form of renal replacement therapy or transplantation if they so choose. There are some individuals that decide not to undergo dialysis, and while they inevitably have a shortened life expectancy, the quality of life they may have may be greater than compared to being on dialysis. However, this is a very personal decision based upon an individual's value judgment, and the decision should be done in consultation with the patient's entire care team. By far the most common causes of chronic kidney disease here in the United States are diabetes and high blood pressure. This is followed by glomerular diseases and other types of kidney diseases seen here in this pie chart. Hence, when we are evaluating the etiology of a patient's chronic kidney disease, we usually will rule out diabetes and high blood pressure first. Additionally, diabetes and high blood pressure are the strongest risk factors for development and progression of chronic kidney disease. Because these are the strongest risk factors, our management relies heavily on controlling hemoglobin A1C values to less than 8 if possible, and blood pressure targets to less than a systolic blood pressure of 140. Aside from diabetes and high blood pressure, there are other modifiable and non-modifiable risk factors for chronic kidney disease. Heart problems, obesity, and tobacco use are other risk factors that can predispose to progressive chronic kidney disease, and it's important that we counsel patients to try to lose weight and quit smoking if possible. Non-modifiable risk factors, including family history and age, are unfortunately not something that we can control. Yet but it is helpful to counsel patients, as they get older, they will inevitably lose a small amount of kidney function over time. People with strong family histories of kidney disease, such as those with autosomal dominant polycystic kidney disease, should counsel their family members as well that they are at high risk of developing the same disease. While we do not routinely recommend genetic screening or counseling to those under the age of 18, adults with family history of polycystic kidney disease should be screened for and treated with novel agents that have been designed to slow the risk of chronic kidney disease progression in the setting of polycystic kidney disease. There are many ways that people develop chronic kidney disease. Patients who have an acute kidney injury that is prolonged and does not recover can of course lead to chronic kidney disease. Additionally, people who have multiple episodes of AKI can also develop chronic kidney disease over time, as well as repeated injury that results in irreversible damage to the renal parenchyma. Lastly, patients can have some underlying risk factors such as diabetes and high blood pressure that results in a subacute decline of their renal function over time that leads to chronic kidney disease. Keeping this in mind, I usually go through the following 3 steps to evaluate the etiology of somebody's CKD. First, I determine whether the patient has a history of diabetes or not, since this is the most common cause of chronic kidney disease here in the United States. If they don't have diabetes, I check our blood pressure history, and if they have a history of hypertension, as this is the second most common cause of chronic kidney disease in the United States. If the patient has neither diabetes or high blood pressure, then we want to do additional workup to try to see if there's any other causes of kidney disease, such as glomerular etiologies, tubular, interstitial, or other vascular causes that we discussed as the etiologies of acute kidney injury. What is the pattern that we expect when we see patients with chronic kidney disease due to diabetes? Many of these patients do have associated diabetic changes to their eyes and nervous system, which results in diabetic retinopathy and diabetic neuropathy. Most of these patients have hemoglobin A1C values that have been uncontrolled for many years, especially above 8%. Patients who have A1C values that are even higher than this have a higher risk of progression of kidney disease, and a lot of times they will develop kidney failure over the course of 5 to 10 years. Diabetic nephropathy can also result in various degrees of proteinuria, from minimal proteinuria all the way to nephrotic range proteinuria. It is also interestingly unusual for patients to have hematuria in the setting of diabetic nephropathy. So if a patient does have hematuria, or even microscopic hematuria, then it is reasonable to rule out lower urinary tract issues as well. There are some things to keep in mind when you are treating patients with diabetes and chronic kidney disease. As the kidney disease worsens, insulin in the body tends to stay active longer and is no longer secreted through the kidneys. This means that for most patients with diabetes, the glucose control may at times get better when patients' kidney disease worsens. It is not unusual that you see hemoglobin A1C values fall as the kidney function worsens, and patients may come to you telling you that their diabetes is much better controlled. Unfortunately, the diabetes has gone on for so long that it has resulted in permanent damage to the kidneys at that point. There are also some medication effects that you will want to be aware of when you are dealing with patients with diabetes and chronic kidney disease. Many of us like to use metformin as first-line agents for diabetes, but one must keep in mind that with GFR less than 45, the maximum recommended dose for metformin is 500 milligrams twice a day. And once a GFR drops below 30, metformin should be discontinued due to the increased risk of lactic acidosis. Similarly, the medication glyburide has several active metabolites that are excreted in the urine, and when renal function falls, these active metabolites can persist in the body and cause hypoglycemia. Hence, we generally recommend avoiding glyburide in patients with chronic kidney disease. Other medications such as glipizide, glimepiride, TZDs, and SGLT2 inhibitors have been shown to reduce the progression of chronic kidney disease in both diabetics and non-diabetics. However, there are currently no data to suggest any benefits of using SGLT2 inhibitors once a patient has transitioned to dialysis. There are new medications such as GLP-1 antagonists that are generally well tolerated in patients with chronic kidney disease, even into dialysis. What about for patients who have diabetes but no known kidney disease yet? We generally recommend monitoring their kidney function with both a serum creatinine level and urine microalbumin to creatinine ratio to evaluate for proteinuria annually. In patients who have diabetes and chronic kidney disease, we generally want to try to optimize their risk factors and minimize their proteinuria. In this case, we generally want to try to control a patient's blood pressure to less than 140/90 and start them on an ACE inhibitor or ARB, especially if they have high blood pressure. We can use medications such as ACE inhibitors and ARBs to try to minimize somebody's proteinuria to less than 1 gram per day. And again, the latest guidelines suggest using SGLT2 inhibitors for patients with diabetes to both minimize proteinuria and decrease the risk of chronic kidney disease progression in patients with a GFR greater than 25. Now let's take a look at patients who don't have a history of diabetes and who also have chronic kidney disease. Hypertension or high blood pressure is the second leading cause of chronic kidney disease here in the United States, and we typically don't see any proteinuria or hematuria in most cases of hypertensive kidney disease. These patients generally have a history of very high systolic blood pressures, especially over 160 over a very long period of time. While we generally see hypertensive kidney disease in older individuals, it is possible to see this in younger patients who have uncontrolled high blood pressure. However, if we do see somebody who is young with high blood pressure, it is usually a good idea to look for secondary causes to see if there's any underlying reasons for these patients to have high blood pressure that can be easily treated. Once we have ruled out high blood pressure and diabetes as the top two causes of chronic kidney disease in patients, I generally look for any evidence of glomerular diseases or cystic kidney diseases, especially if they have a strong family history of kidney disease. We can use our general workup of blood and urine test, as well as an ultrasound to rule these out. What should the blood pressure targets be for my patient with and without kidney disease? Per the latest 2021 KDIGO guidelines, adults with high blood pressure and chronic kidney disease should be treated with a target systolic blood pressure of less than 120 if tolerated. The first-line antihypertensive agents should be a renin-angiotensin-aldosterone system inhibitor, especially for patients with diabetes and/or proteinuria. For patients without diabetes or proteinuria, or patients without chronic kidney disease, thiazide diuretics and calcium channel blockers are also reasonable first-line antihypertensive agents. Usually these patients will have a combination of medications to get their blood pressure under control. However, once a patient is requiring 3 or more antihypertensive agents, feel free to consult us for workup for resistant hypertension or management with other 3rd, 4th, or 5th-line antihypertensive agents. Additionally, we also get asked about older patients and how aggressive we should be with their blood pressure goals. There are some studies which have suggested an intensive BP goal of 120 or lower may be beneficial in patients even into their 70s and 80s, but these studies do show a high risk of complications, including hypotensive episodes. For patients who are even older, we generally will follow a more conservative regimen depending upon life expectancy and quality of life, taking into consideration polypharmacy and the side effects from multiple medications. Getting back to the evaluation of chronic kidney disease, remember that duration is important, and that chronic kidney disease requires abnormal kidney function for more than 3 months. If the duration is less than 3 months, these patients may have chronic kidney disease or an acute kidney injury, and the kidney function test should be repeated to assist with distinguishing between an AKI and a CKD. As I have discussed before, it is important to take a good medical history, as a lot of times the etiology of chronic kidney disease can be determined by medical history alone. These include a history of uncontrolled diabetes or high blood pressure, family history of kidney disease, use of nephrotoxic medications such as NSAIDs, ibuprofen, naproxen, etc., and a history of kidney stones, or other obstructive causes of kidney disease. If despite a good medical history you are still unable to ascertain the etiology of a patient's chronic kidney disease, feel free to send the patient over to us where we can continue the evaluation with both blood tests and biopsies if necessary. The workup for chronic kidney disease is very similar to the workup for acute kidney injury. We typically start with obtaining a renal ultrasound to look for any evidence of obstruction, but we also look at the sizes of the kidneys to help us determine the chronicity of the kidney disease. Normal patients will have a kidney size of anywhere between 10 to 14 centimeters, and if the kidney sizes are smaller than this, it would suggest that the patients had had chronic kidney disease for a long time. If a patient's kidney size is large, this may suggest a couple of things, including the presence of polycystic kidney disease, hyperfiltration, and diabetes, and may be a normal finding in patients who are pregnant. Aside from proteinuria, we also obtain either laboratory workup including hepatitis B and C panels, ANCA titers, ANA titers, and complement levels to help us determine if there's a pattern of injury that's present to guide us on our diagnostic path. Ultimately, if the workup is negative, we can perform a renal biopsy to look at the pathology under the microscope and ascertain the pattern of injury that way as well. Remember that the kidneys do 3 important functions in our body, including 1, getting rid of excess water, 2, balancing electrolytes, and 3, getting rid of toxins from our body. Additionally, our kidneys also have important roles at producing certain key hormones that regulate our blood pressure, our blood levels, and bone health, as we have discussed these in previous lectures. So it is expected that once our kidney function deteriorates, we may have issues and complications that lead to abnormalities in water handling, acid-base and electrolyte handling, anemia of chronic kidney disease, and calcium-phosphorus metabolism issues, which we term mineral and bone disorder related to chronic kidney disease. In the next few slides, we will talk about each of these individually. Water handling is usually impaired in patients with chronic kidney disease due to the destruction of glomeruli and tubules that result in the inability of the kidney to excrete free water. Additionally, tubular destruction can lead to water and salt retention that results in edema and high blood pressure. In this case, diuretics are the key to assisting our remaining kidney function at the water handling process. In the early stage of chronic kidney disease, fluid retention may not result or can be easily managed with fluid restriction. Indeed, there are other conditions that can lead to fluid retention aside from kidney disease, and these should be explored in the setting of mild chronic kidney disease. It is important that patients be reminded that it is not necessary to drink 64 ounces of water in a day in order to maintain good hydration, especially in the setting of chronic kidney disease, and the inability to excrete that excess free water that we find in chronic kidney disease. We typically see these issues at stages 4 and 5 of CKD. If fluid retention and dietary changes are insufficient to allow for a euvolemic state, we can initiate various diuretics to assist the kidneys at removing excess salt and water. We generally start with thiazide diuretics such as hydrochlorothiazide or HCTZ, and then move on to stronger loop diuretics such as furosemide or bumetanide. At later stages of chronic kidney disease, it is not unusual to require higher and higher doses of diuretics in order to maintain a euvolemic state. Once the patient becomes unresponsive to diuretics, it is usually necessary to transition that patient to dialysis, where we can continue to remove fluid, among other functions of the kidney that dialysis replaces. We also frequently see the development of acidosis in patients with chronic kidney disease that is usually manifest in a decrease in a patient's bicarbonate levels over time. In very late stages of chronic kidney disease, we can also see the development of a high anion gap metabolic acidosis due to the retention of acidic waste products that are produced as metabolic byproducts. Remember again that our BUN levels are only a surrogate marker of toxins in our body, and high levels of BUN can indicate that the presence of these metabolic byproducts are not being secreted sufficiently by our kidneys. Research studies have suggested that the acidic environment that develops with chronic kidney disease is harmful and can predispose to progression of chronic kidney disease. So we usually treat metabolic acidosis with supplemental bicarbonate or a change in the patient's diet. Patients who consume a more vegetarian diet have been shown to decrease acid generation, which can help preserve the kidney function over time. If a patient is unwilling or unable to increase the amount of fruits and vegetables in their diet and decrease the amount of animal protein, which is more acid generating, we can provide them with sodium bicarbonate tablets, which are absorbed in the body and neutralize the acid in our serum. Other forms of sodium bicarbonate include citric acid or sodium citrate, which is then converted into sodium bicarbonate in the body through the liver. In patients who are in the hospital, we can sometimes correct a patient's acidosis by using an IV infusion of sodium bicarbonate as well. And if all else fails, dialysis can also correct a patient's acidosis by removing excess acid and providing the patient with large amounts of sodium bicarbonate. Anemia of chronic kidney disease also results from the inability of the kidneys to produce the hormone called erythropoietin. As with all causes of anemia, it is important to rule out GI bleeding and iron deficiency before attributing the anemia to chronic kidney disease. We usually see anemia and chronic kidney disease in stages 4 and 5, and we usually treat these patients by ensuring 1, their iron stores are adequate, and then 2, by providing the patients with erythropoietin stimulating agents such as Epogen, Aranesp, and Mircera, among others. For dialysis patients, we typically aim for a hemoglobin level between 9 and 11, and for non-dialysis chronic kidney disease patients, we typically try to aim for a little bit higher hemoglobin level between 10 and 11.5. When it comes to calcium and phosphorus metabolism, these are affected by chronic kidney disease due to the inability of the kidney to excrete phosphorus, as well as the inability to convert inactive vitamin D to active vitamin D through the kidneys. The lack of active vitamin D results in the inability of the gut to absorb calcium and phosphorus. However, since the kidneys are affected such that they are no longer able to sufficiently excrete phosphorus, this results in the combination of a low calcium level, high phosphorus level, and high parathyroid hormone levels. The treatment of mineral metabolism issues in chronic kidney disease is supposedly aimed at preventing long-term outcomes such as an increased risk of fractures or cardiovascular disease. We typically want to replete vitamin D stores in earlier stages of chronic kidney disease when the kidney is able to convert the inactive form of vitamin D to active forms of vitamin D. At later stages of chronic kidney disease, we must provide the patient with active forms of vitamin D called calcitriol, since the kidney will only be able to convert a small amount of the inactive vitamin D to active vitamin D to have its intended effects. There are also other forms of active vitamin D analogs that are on the market nowadays that do not necessarily increase the gut absorption of calcium and phosphorus as much as the active form of vitamin D, calcitriol. These medications can be used to lower parathyroid hormone levels in a patient to reduce the risk of fracture. We also want to use phosphorus binders to decrease the phosphorus levels in the body. Additionally, we do not usually provide patients with extra calcium, since a high calcium combined with a high phosphorus level can lead to a higher risk of calciphylaxis, which is a severe form of calcium phosphate deposition in the skin tissue that is painful and ultimately difficult to treat. Unfortunately, when it comes to treating chronic kidney disease, we are usually left to treat the underlying cause of the chronic kidney disease, especially the major risk factors of diabetes and high blood pressure. Many times, even with control of high blood pressure and glucose, the kidney function will stabilize out over time. In the event that the kidney function continues to progress despite all of our interventions, we will eventually prepare the patient for renal replacement therapy, which means either dialysis or transplantation, if the patient is a good candidate for transplantation. In addition, we will also focus on managing the complications of chronic kidney disease with the medications that I previously discussed, and/or dialysis when we see these patients in our clinic. When helping us manage patients with chronic kidney disease, it is important to remember that we want to avoid nephrotoxic agents such as non-steroidal anti-inflammatory drugs, CT scans with IV contrast, and limiting the use of hypnotics, muscle relaxants, benzodiazepines, and narcotics, as these medications can last longer in a patient with kidney problems compared to somebody with normal kidney function. Usually, the low-dose baby aspirin of 81 milligrams a day does not cause significant chronic kidney disease or kidney injury, but if you have an unexplained case of AKI without any other etiologies, it may be reasonable to discontinue the baby aspirin. Also, a lot of medications do need adjustment when it comes to patients that have advanced stages of chronic kidney disease or who are on dialysis. So before you start any patients with any new medications, I would highly recommend that you quickly check the kidney function and that the dosing is appropriate for that kidney function. As we wrap up, I want you guys to remember the following take-home points. Remember that chronic kidney disease is defined by a period greater than 3 months, so it's necessary to follow patients for at least 3 months before you diagnose them with chronic kidney disease, especially if you don't have previous lab tests for that patient. Second, because there's a very high risk of getting chronic kidney disease from diabetes and high blood pressure, it is important to manage these risk factors especially well, especially before you notice any problems with their kidneys. The management of these risk factors will eventually help stabilize out their kidney function over time. In most cases of chronic kidney disease, the medical history will provide a good reason for why the patient does have chronic kidney disease. But in the event that this is still uncertain, please feel free to refer them to us so we can do additional testing or biopsies to understand what is happening to the kidney and help treat the kidney before it gets too late. We also appreciate if you can help us to manage some of the complications of chronic kidney disease, such as high blood pressure, fluid retention, anemia of kidney disease, and metabolic bone disease. When patients get to more advanced stages of chronic kidney disease, also help us prepare them for renal replacement therapy, including dialysis and/or transplantation. And finally, try to avoid any nephrotoxic agents that can potentially harm the kidney further in the setting of chronic kidney disease, and especially dose-reduce any medications that can be affected by the kidneys. Thank you very much for your time and attention today in our discussion of chronic kidney disease. Please feel free to contact me if you have any further questions.